We're so glad to have, excuse me, uh, Dr. Ben on, and I'll introduce her in a moment. So my job basically is just get the party started, so to speak. And Dr. Gavin, y'all see me before, you know I am most likely. And so this is me, of course. I'm Dr. Reynolds, and this is my senior consultant for chronic disease. He covers everything, to be honest about it. Anything that's chronic disease, he's board certified in that too. He's a board certified endocrinologist and board certified also in internal medicine. We've been so blessed and fortunate to have Dr. Gavin on Team CHP. Now, joining us today will be Dr. Well, this you guys have already seen this. Most of you have anyways. I have to make a comment about that. This is being made possible. That is, the webinar is being made possible by the state of Florida Department of Health, Minority Health / Closing the Gap program. So it is a program that's been around since 2004. That means it's a pretty solid program. We happen to have the largest grant since they started this program, 2004, by far, right? We have approximately $1.5 million of a grant that covers 4 different counties. So you guys will know this. If you logged in, hopefully you'll put in one of those cities in one of those counties. We cover from Orange County, which covers Mickey's County, okay? We cover Palm Beach County. Well, we know it's in Palm Beach. I just move on from there with Palm Beach. And we also cover Broward and Miami-Dade County. Our main thrust is to bring education and awareness, and in some cases, treatments to the chronic disease that I have identified as the CEO and president of Central Health Motion. I have been requested, we got that grant, we got it granted to us, and that's to cover cardiovascular disease and diabetes. Little did I know that I would go off into many different segues of this, and thanks to Dr. Gavin, the gentleman who is our curriculum coordinator, I would never have thought about oral health, gynecologic issues, and how it also impacts chronic disease. So we're going to have a whole bunch of different mixes of things coming up. So I'm so thrilled to have Dr. Fern, I hope I get this right, Choi Bent. Is that close enough?
That's close enough. Tyson Choi Bent.
Tyson Choi Bent, okay. And Dr. Bent, could you tell us something about your background?
Okay. Good morning. I'm a board certified OBGYN. I have been in clinical practice for more years than I'd like to admit, which is about 30 to 35 years. I practice down in Broward County. I love what I do. I enjoy educating women about what's going on with them gynecological, and I feel very honored to be a part of this discussion because it really helps to focus on how those GYN conditions does accelerate the development of the chronic diseases, and that kind of also explains the great disparity or the worst outcomes that we see in our women. So thank you for having me.
Thank you so much. Okay, Dr. Choi, it's all yours.
Thank you, and good morning again, everybody. As I said, I am very excited to do this. One of the things I pride myself in my practice over the years is educating my patients, and I try my best to educate women to understand what is going on in their bodies when we talk about the various GYN conditions. And in doing so, and having some kind of understanding, I think they're better able to make well-informed decisions and work with their doctor to see what's the appropriate therapy that may be needed. So this morning we're going to talk about what are common GYN conditions and what's going on in the body that leads to the growth or to the development of chronic disease such as hypertension, diabetes, asthma, and cardiovascular disease. Next, please. So to review what we're hoping to accomplish this morning, we're going to look at GYN conditions such as fibroids, endometriosis, cancers, STDs, and another condition that I see very often, polycystic ovarian syndrome, and the environment that's created creates this chronic inflammation. We see these conditions in devastating frequency in women. However, we see a disproportionate of impact of these conditions in African American women. Various reasons why that may happen. They have earlier onset, they have more severe symptoms and worse outcomes. You'll hear me talk about a term chronic inflammation. And when I say chronic inflammation, that's important because that's the pathway that causes this condition to lead to development of cardiovascular disease. If you think of when you get a cut on your outside, the body has an immune system that's going to try and heal that. And in doing so, it releases certain chemicals to try and repair the body. When it does so, when you see you get a cut, you get inflammation, swelling, bruising, etc. Chronic inflammation, that system never gets healed, so it never gets turned off. So what is happening is the body is constantly being insulted by the chronic inflammation, and that leads to subsequent damage of the tissue, especially at the vascular level, and that's what's contributing to the development of the chronic diseases. So that's more or less talks about the pathways to chronic diseases. And again, we see it much higher in our population, and we hope to touch on why that happens. So early detection of these conditions, education, screening early is very important for us to be able to break this cycle and you know, attack this earlier in the process. Next slide. Next, please. Uterine fibroids. Okay, what are uterine fibroids? Uterine fibroids are benign tumors. Again, they're benign tumors that we see that develop in the womb. They commonly develop on the outside, inside, or on the surface. They affect about 80% of women by age 50. It's one of the most common GI connect conditions, but it's not really recognized or diagnosed early because a lot of the symptoms are not necessarily related to they don't think of fibroids. Black women, if you look at the side, Black women are 3 times more likely to be diagnosed with fibroids. Earlier onset, larger fibroids, more severe symptoms such as heavy bleeding, pelvic pain, and subsequently infertility. I think the most common thing I see is the heavy bleeding, and a lot of our women have fibroids, but again, they're thinking it's just the bleeding and the pain, etc. This, hopefully, by the end of this discussion, you'll have an understanding of what else is going on. Just as the third bullet point, that creates that chronic inflammation that I'm talking about, where there's damage of the blood vessels, and that can lead promoting atherosclerosis and the key drivers of heart disease. The key thing to get away here, get from this, we're more likely to see it in Black women. 1 in 4 Black women by age 18 to 30 are going to be affected, compared to only 6% of white women in that same age group. It is most commonly seen in the reproductive years. Next. Next. Sorry. Endometriosis. Okay, what is endometriosis? Bear with me when I kind of break this down for us. The endometrium, the tissue that we shed as women every month, is called the endometrium, and that tissue is within the womb. Where endometriosis is when we see that particular tissue, the endometrium, in other areas outside of the womb. And if you look at the diagram of the uterus in the back, you see that it can be on the outside, on the surface, on the inside. What most common areas is the ovaries, the tubes, the colon, and wherever that tissue is, it's under the influence of the hormones that our ovaries produce that regulates our cycle. Now, when we have our period or when we ovulate, we create inflammation. That's what happens. And as I said, if wherever this tissue is, there's inflammation around it. So for example, if it's in the pelvis near the colon, the bowel, there's going to be a lot of inflammation there, swelling, and that presents itself as pain. So you may have also some bleeding there in areas that you shouldn't be having any kind of bleeding. And the chronic insult of that inflammation to the tissue around us is what leads to the chronic pelvic pain, infertility, and essentially fatigue. Now, it's underdiagnosed in women, but more so in Black women, because I have patients, that they come in and my menstrual cramps are so severe. They have back pain. I have back pain even when I'm not having my period. I have blood in my stool. Some women that you may have the tissue in their nose, and they may have nosebleeds, and not a lot of clinicians may correlate. Well, maybe this woman has endometriosis, so it's undiagnosed. Globally, it's supposed to be 10% of women throughout, but I think it's much less, much more than that, because oh, she's having pain. It's her period pain, and they don't explore it any further. The inflammation, as I talked about, triggers the metabolic dysfunction. And again, remember, this is down at the level of the blood vessels. Blood is important to our tissues. So if we're in any way compromising the blood flow there, can lead to the development of the diabetes and cardiovascular risk. The last point there, again, the inflammatory burden from the endometriosis accelerates the risk for the development of type 2 diabetes and cardiovascular diseases. These conditions are already disproportionately high in Black women, and then if they go undiagnosed in a much later on, by the time the woman of color is diagnosed, she really has severe disease. Um, Next.
Dr. Ty,
Mm-hmm.
yes, one question first of all, anyone who has a question, you ladies, please feel free to ask. I don't want to be the first person to ask a question about a gynecologic problem, but I will. Okay.
Dr. Ben, if I could just introduce just one comment, because I want to bring the audience's attention to the fact that they are seeing this word inflammation on a fairly frequent basis. They're now starting to see terms like metabolic dysfunction and insulin resistance, all coupled to elevated cardiovascular disease risk. And we're going to be coming back to that subsequently, time and time again.
Thank
Yes,
you.
yes. What I was going to say though is this is did not realize that endometriosis can go as high up into the nostrils.
Yeah. If you it kind of goes back to embryology when we were developing in the womb, and as the tissue travels to where it's supposed to go to and it differentiate into the uterus, the ovaries, etc., there are little deposits of undifferentiated tissue, and you may have some that stay in by the brain, in the nose, in the colon, where you may have bloody stools. But yes, we can see that sometimes during their period, women will have nosebleeds. And that's because, like I said, wherever this tissue is, I've seen women that sometimes have seizures during their period. Wherever this tissue is, it's still under the influence of the hormones that influence our periods.
I have a question.
Hmm.
Hi. Good morning.
Good morning.
My question is regarding the incidence and prevalence among Black African American women. And is there some type of genetic component to this as well, that it occurs more so in Black women, other than the other factors that you mentioned?
I don't necessarily think there is an increased genetic component. We really don't understand what causes endometriosis, but what it happens, just like I mentioned, is it goes undiagnosed, and because we don't pay attention to the symptoms. But I'm not sure there's a certain genetic cause that is higher in women of color. There might be with regard to fibroids, but not necessarily endometriosis.
Oh, I'm sorry. I meant fibroids. That's what I was referring to.
Yes,
I'm
there.
sorry.
Okay, so there is the etiology for a lot of these conditions is multifactorial, but we do think there's a genetic component when it comes to fibroids. We do see families that most of the women may suffer from this condition. Yes,
Okay, great. Thank you.
you're welcome.
So since we're on this very condition, I know you had mentioned to me as we had a discussion prior to us having this webinar about sometimes how doctors tend to treat endometriosis totally incorrectly, and in fact can make them worse. I think it was dealing with the outer line, the shelling off of the endometrial wall.
Mhm.
Can you
Well,
explain that a little bit?
okay, that's very important, and the reason why is this. Women are there, typically most women will have pain during their period. The first line of therapy, of course, we treat with pain medication or we treat with birth control pill. The thing that the clinician has to realize, if you have your patient that you're saying, okay, take Motrin, take Aleve, take all of that, and that may help. If she keeps on coming back and saying, I'm having pain, even when I'm not having my period, or this is not helping anymore. It's important for us to think about endometriosis because that pain that she's having when she's not having her period may be a result of the scarring that occurs from the inflammation of the tissue, wherever that tissue may be. So that's why it's undiagnosed, and we kind of, oh, just put her on birth control, just treat her with pain. But you have to look further. And it's not, it used to be you would have to do a laparoscopy or do some kind of surgical intervention to be able to make the definitive diagnosis. Now it's not. Now we can use clinical presentations to try and make the diagnosis. And the important thing, however, is when we offer treatment, if they're not responding, at that time you may want to do a laparoscopy and take a look. But the bottom line, the treatment usually is to monitor the hormones. There are medications now that decrease the amount of hormones that's produced during the cycle, and that shrinks the endometrial implants wherever that may be. So we don't jump right away to surgery because we've found over the years too that surgery within itself, to go ahead and make the diagnosis, can also cause scar tissue. So we try to treat this medically. And when doing surgery, it should be done in the hands of somebody who's very skilled in doing this kind of surgery and removing the endometrial implants from the areas of the body and the pelvis that is typically not seen. And if I may, I'd like to make a comment about something I experienced a few years ago. I've been trained in robotic surgery, and robotic surgery is one of the main type of surgery now used to treat endometriosis. Why? It's less invasive, so it causes less inflammation. Well, during my training, it's a great form of surgery. It's very detailed, high definition, and it's very. If you see an endometrial implant, you can skillfully remove the implant without destroying the tissue. Well, I went to a seminar, and one doctor was teaching us this new way of treating endometriosis with robotic surgery. Essentially, what this man was doing was going in to women and essentially peeling off the layer of tissue called the peritoneum, the peritoneum in the pelvis, peeling it off. And that was his way of saying, this is how you treat endometriosis. Well, it irked me because what he's creating is an environment where you're having the tissue, they're not having that protection. So you're going to have more scar tissue, and it just was so upsetting to me because you are now creating scarring and more chronic pelvic pain in these women. And that's why it's so misunderstood as to how to treat this. Right now, we're trying our best to treat it medically by suppressing the hormones, the estrogen that stimulates its growth. And even if you eventually have to go and do surgery, we may give you a course of this medication so that when we go in to remove it, the lesions are much smaller. But it was just devastating for me to see that somebody was actually talking about doing this to women. So again, it's undiagnosed in all women, but more so in Black women. And then when it is diagnosed, they may not be getting the skill of the surgeon that needs to do that. It causes that systemic inflammation that we were talking about. Again, the systemic inflammation causes damage at the level of the blood vessels, and that accelerates or helps in the development of the chronic medical conditions that we've been talking about. Any other questions? With that understood. Okay, cervical cancer. I want to spend a little bit of time on cervical cancer. When a woman says she's going to go and get her annual exam, her pap smear, the one thing she's thinking about, I'm getting my pap smear, and this is a screening test for cervical cancer. The cervix is the opening of the womb that's sits in the vagina. The guidelines have changed towards this. We now know that it's not just about the cells, but it's also about the human papillomavirus. The human papillomavirus, as it says, is a virus, and it's linked to 90 to 99% of cervical cancers. So now we don't just look at the cells, we look at the presence or absence of the HPV virus. You know, like how we had COVID-19, there are different strains of viruses and they're numbered. So we have a class of viruses, HPV virus, that we consider high risk. The guidelines now say we should really not start doing PAP till age 21 to age 21. And 21 to 29, we look just at the cells, which is the PAP. And then they recommend screening every 3 years. And listen to what I'm saying, in low-risk patients. Who are low-risk patients? Those are patients who have an intact immune system. So we start at 21 to 29, where we're just looking at the cells. From 30 to 65, there's 3 different options. One, you can just look at the cells, and that should be done every 3 years. But because we have that high correlation with HPV virus, we also want to screen for the presence or absence of HPV. So the second option, which is what most of us do, is a pap smear and screen for the HPV virus. And that's recommended every 5 years. And then the last, every 5 years. And then the last one, of course, is the HPV alone, which I think is every 3 years. Again, these are guidelines that apply to quote unquote low risk patients, that have an intact immune system. But if you think about our patient population and women of color, Black women, do we really have an intact immune system as compared to our white counterparts? No, not necessarily. So you really have to think about your screening and individualize it on each patient. And as you see, while they may say there's similar incidence between Black women and white men, it's a little higher in Black women. It's actually about 9% versus 7.6%. The key thing to take away from this, and you'll see when I talk about other cancers, is that Black women 75% higher risk of dying from cervical cancer. And that's important. So, you may go get your pap smear or whatever, and they say, don't come back for 3 to 5 years. Have a discussion with your gynecologist about, does that really apply to me? I kind of go somewhere in the middle, especially if I know the patient very well. Another reason for the gap is the delayed diagnosis. Like, women are not following up. They may not have access to the appropriate doctor, a gynecologist. Insurance reasons is one of a common reason. And the structural barriers to specialist care. Let's say we find abnormal cells. Let's say we find cervical cancer. A lot of us, as women of color, don't have the access to the specialist who's the GYN oncologist. So it's important, I think, as a clinician, to individualize this, educate my patients about how important this HPV is, and decide how you're going to screen this woman. And of course, insurance and transportation gaps, a big issue. But the key thing to take away, even though the incidence is somewhat similar in Black women and white women, take a look at what the mortality rate is for women of color and Black women of color, particularly Black women.
I have a question.
Mm-hmm.
Um, I'm I'm concerned about the woman that's over 65.
Very
So
good.
what do you do for those women who no longer, they tell you that you don't take this test anymore?
Okay, very good question. The recommendation is that we can stop screening for women over 65, provided she has had 3 or more normal pap smears, negative HPV within the last 10 years, and at least within the last 5 years. Again, however, you need to individualize the patient. I tend to still do it, but I look back at the history of the patient. Is this somebody I've been following for years? I have patient that comes into my practice that this may be the first time I'm seeing them, and they're like 65, 66. I will do a screening because I don't have records to show what their history has been in the past. So you need to again have that discussion with the gynecologist. They may say, "Oh yes, you don't need to do it." But talk to them. They should be asking you, have you ever had an abnormal pap? When was the last pap? Have you had 3 or more normal paps within or negative HPVs within the last 10 years? Does that answer your question?
Um, I think it does, but I'm 78. So,
Okay.
I think the question of cervical cancer, anything, any disease, is when you say that after a certain age, you don't have to have that test, I'm concerned.
One of the things that we say that is cervical cancer is a very slow growing cancer, number one, very slow. So if you have not had any evidence, any abnormal cells or positive HPV within the last 10 years or so, the likelihood of you developing cervical cancer and dying from that is very low. So that's something to take in consideration as well. But I still continue to do it if a woman comes to me and she's still concerned, and I will continue to do so until insurances, because that's what's coming next. Insurances are going to stop covering it for women over a certain age. But
Okay.
have that discussion with your gynecologist. And I do it sometimes just for peace of mind for a lot of my patients. But I have seen patients, that woman over 65, where she has developed cervical cancer after age 65. Remember, a lot of the research that we see about these various cancers and treatments, so there are not a lot of women of color that are involved in the study groups in the research of this. So it's so important that you talk to your patient and just treat them individually and treat them as you think they need to or what would make them feel comfortable.
See, Dr. Ty, I have a question. I'm here with a group of ladies, I think about maybe 10 or 12 of them. And one lady asked me a question, but I want her to ask you the questions about, I think you already covered it, but I think she may have missed that. And you want to ask this question?
Yes. Hi. So my name is Annette.
Hi, Annette.
Hi, because I went to my it's my OBGYN, and
Mm-hmm.
she told me about my PAP. She said my PAP, I can have it 3 to 5 years. But that was concerning to me because as Black women, so we're at a higher risk. So I told her, I said, no, I want mine done every year. So how relevant is that for us?
Okay. As I said, it depends on your history. The guidelines are looking at your history of PAPs in the last 3 to 5 years. But again, these waiting 3 to 5 years is dependent on your immune system. I would say if you have other underlying, hypertension, diabetes, things like that, you may want to do it more frequently. I've not gone to 5 years. For patients that I know and I have I've known them for well, I may go 3 years. But it's not as if this is somebody you've been seeing for the last 10, 15 years, and if it's documented that you've had normal PAPs and negative HPV. Remember, it's not just the PAP. The PAP looks at the cells. It's also the presence or absence of the human papilloma virus. If she has rexes that shows you've been normal, you're healthy, you don't have any hypertension or anything that's affecting your immune system, I think 3 years is okay.
Okay.
And I will do it as long as, because I want my patients to feel comfortable, as long as we're insurances are allowing us to do it.
Okay, we can move along.
Thank you.
Okay, next.
Good morning, Dr. Bit. My name is Zaya Anderson, and I do have a few questions.
Mm-hmm.
So I was recently diagnosed with anomyosis, PCOS, and endometriosis. I've spoken to many OBGYNs and many gynecologic surgeons, and they all recommended hysterectomy. I am 21 years old, and hysterectomies is kind of, I know it's very, very invasive, and that's not something I want to do as a 21-year-old in college. Um, and I was looking for holistic approaches. I've been told that anomyosis is an abnormal development of my uterus.
Mm-hmm.
But for the endometriosis and PCOS, I was told that it also can be a reflection on my diet. Is that true? And if so, what type of diet should I be on to reduce my symptoms and pain? I've been to the ER several times for abnormal abdominal bleeding. Um, and just extremely long menstrual cycles that last up to a month or more. So, what would you recommend with patients with this type of issue and the severity of this issue?
Okay, so very good question. Polycystic ovarian syndrome. It does not necessarily mean it's a disease that's a result of hormonal abnormalities and metabolic abnormalities. The woman with polycystic ovary syndrome has the potential to develop diabetes. So it's not necessarily just about diet. That woman really needs to see her endocrinologist so that can be screened for diabetes, because that woman typically is insulin resistant. And when you develop the diabetes, that can also lead to kidney disease, etc. So it's not as simple as changing your diet. That woman needs to be thoroughly evaluated for underlying metabolic diseases as well. Now, the other part of it, yes, the hormones. There is a hormonal imbalance, and the imbalance is such that a woman does not ovulate every single month, so she may not have her period for months. She may then all of a sudden she has it 3 or 4 months later, and she bleeds heavily. Well, not having that imbalance, not having your period every month creates what we call an estrogen dominant environment, and that can put her at risk for precancerous cells actually in the womb. So it's not as simple as changing your diet. It's looking at the metabolic part of it, and also offering her options where we can somehow regulate the hormones. That might be in the form of birth control pills, so that she can have her period every month, and not just building up the lining, and then she has heavy bleeding and anemia. The thing with polycystic ovarian syndrome, they say diet, but it's not that easy. polycystic ovarian syndrome patients have a harder time losing weight. And because the weight is there, there's greater inflammation, there's greater risk of developing the other chronic conditions we're talking about. And it's a vicious cycle. So just changing the diet, not necessarily. You probably will need some medical intervention, and you may need some hormone therapy. Now, hysterectomy, you said you were age 21?
Yes,
Is
ma'am.
that
I'm
right?
21. Yes, and I've been on several different types of birth controls that haven't done
Hmm.
anything but made my symptoms worse to where now
Okay.
my menstrual pain is so intense I pass out. And I
Okay.
am now bleeding months at a time, not just like a 4 day menstrual. I'm saying 30 days at a time, straight menstrual bleeding. And
Hmm.
then it stops for about 2, 3 days, and then it comes back again for the same period of time. So,
Yeah. I believe it is a very frustrating condition, especially in white women, in young women and women of color. But remember, I mentioned before that a lot of these GYN conditions are stimulated by hormones. Just like with the fibroids or the endometriosis, there is a medical option to try and suppress that hormone, that estrogen. It may put you in a state of perimenopause, menopause for a while, but the idea is if we can suppress the effect of the estrogen, that can somehow alleviate the symptoms and the inflammation. So that's an option. If the birth control is not working, that's another option. Unfortunately, hysterectomy is kind of the last resort to do, but it's also when we have this patient that's not responding to any of the medical therapy that we may think to do about that. But I think what I'm trying to do is find a way, especially at such a young age, that we can find the symptoms to work with the symptoms so life is a little bit more tolerable. And by the way, adenomyosis is a type of endometriosis too. It's when the endometrial tissue is in the muscle of the womb. But talk to your gynecologist or your doctors about the brand name of the medication is called Myfimbry. So to talk to them about doing that possibly.
If you guys
yes,
have any,
Okay.
yeah, if
thank
you
you.
guys have any questions, you guys may want to maybe shoot or let's say put in the chat your questions, and then we'll see if Dr. Chai can get back with you on those questions. We have to move it along a little bit.
Okay. Okay. Uterine cancer. So this is cancer of the womb. This is one of the most common GYN cancers in the United States. There's rising incidence across all racial, all ethnicities. However, even though we may have a similar incidence as with our Caucasian counterparts, the key thing to take away from this is the mortality rate. Twice as many women are likely to die from endometrial cancer than than the rate of white women. Why? We'll talk about that at different times here. But one of the things is by the time we are diagnosed, we have developed advanced disease. We are also more genetically, we have a propensity to develop the most severe type of uterine cancer, serous and clear cell carcinoma, which is very aggressive and a lot of times are resistant to the traditional treatment. We also have women that have higher metabolic factors such as obesity, diabetes, metabolic syndrome, and that in turn puts at an increased risk for the development of uterine cancer. So while it's increasing across all ethnicities, women of color, particularly Black women, we are more likely to die from these diseases. Next. Ovarian cancer. Well, ovarian cancer is interesting because by the time we diagnose ovarian cancer in most women, it's at an advanced stage. Why is that? Because the ovary is a very small organ, and sometimes the symptoms that we may have, abdominal pain, bloating, etc., that's overlooked. And it's a little higher, I think, in white women than in black women. But again, the mortality rate is 30% higher. This has to do with, again, having more aggressive forms, later diagnosis, and it has also to with the limited access to the appropriate therapy, GYN oncologist, the robotic surgery. And what I found out when preparing for this, that the treatment that's necessary for those aggressive tumors is also limited. We may not have the aggressive surgery, the removing the lymph nodes, etc. We are not necessarily have access to that. Next. Okay. Cardiovascular disease. Okay. So this is where I kind of going to leave a lot to my Dr. Reynolds and to my endocrinologist here. But what you need to understand here, looking at this, 59% of non-Hispanic Black women by age 18 have some form of cardiovascular disease. It's the number one cause of death among African American women. I hope I presented to you the conditions that GYN conditions because of the chronic inflammation that they create in our body, and that leads to earlier damage, more severe damage of the blood vessels that pushes atherosclerosis and then the development of the chronic diseases such as heart disease. Because remember, our organs need blood. And if we're compromising the blood to get to that's getting to that organ, we're already behind the eight ball. Next.
Before you leave this, Dr. Bent, because if we looked at this slide in a slightly different way regarding its relationship to chronic disease, where you have gynecologic disease, there could be several additional arrows. For example, we've talked about polycystic ovarian syndrome is as much an endocrine disease as it is a gynecological disease. Okay, so it could fit there as a separate type of disease because of its relationship to metabolic problems. But you also have what we've talked to with our audience in the past, dental disease, oral health problems.
Exactly.
That could be an arrow there. And why? What do they have in common? They all lead to chronic inflammation. And this family of peptides that you see abbreviated there, interleukin 6, IL-6, tumor necrosis factor alpha, TNF-alpha, C-reactive protein. These are all the mediators of inflammation, and this is what causes all those downstream events. Endothelial damage that causes the formation of plaques and thrombi, and all of these things are cascading into the damage that leads to cardiovascular outcomes. So there are a lot of things that can feed into where that gynecological disease is feeding into. They all have in common increased inflammation. Obesity is another arrow that can go right into there. So just important for our audience to realize that when we're talking about the relationships between all of these different disease types, it's because they all feed into this convergence point of chronic inflammation and the cascade of events that leads to cardiovascular endothelial damage and cardiovascular events downstream.
Thank you, Dr. Gavin. Interestingly, when preparing for this, I also found that the endothelial damage in Black women seems to be more pronounced than our white women. In other words, we're starting off with already a compromised vessel because of the stresses that Black women have to deal with, that chronic stress, the systemic stress, the racism, all of that. With women, Black women start out with so many social factors, and we're starting that chronic inflammation process even earlier at our baseline. Our baseline is is even worse. So
Yeah,
I
but
thought that was,
we won't have sufficient time to talk about all of the ways in which the social determinants of health can translate
yeah.
into metabolic burdens that feed into this pathway, as you've indicated here.
Okay, thank you. And
What?
next, okay, chronic disease and the link to stroke. Uterine fibroids, endometriosis, as we said, are linked to increased stroke risk because of the chronic inflammation, hormonal dysregulation. Keeping in mind, hormone dysregulation has something to do with all of this too, and leads to the chronic inflammation. African American, if you look at this slide, African American women face stroke mortality 2 to 5 times higher than other racial groups, and throughout all parts of the country. The upper orange bar is referring to the mortality rates in African American women throughout the entire United States. And as you can see, most so in the West and the Midwest, we see highest stroke death rates across the entire country. Okay, next. Next, okay. Heart failure, again, we keep on talking about that chronic inflammation. It's causing damaging to the vessels, damage to the organs. The heart becomes more stiff, and that the vessels become more stiff. That leads to increased risk of the hypertension, significantly higher in African women. The metabolic disease, insulin resistance, obesity, hormonal imbalances, and menopause. The deficiency of the estrogen also can it can lead to that endothelial dysfunction and put postmenopausal women at risk for heart disease. Now, more women, we worry about breast cancers and uterine cancers as we should, but the menopausal women is more likely to die from heart disease more so than from the breast cancer and the uterine cancer. Dr. Reynolds was going to explain a little bit, but maybe Dr. Gavin can, about the heart failure with preserved ejection fraction. I didn't quite understand it. I don't know if you want to
Yeah,
elaborate
well,
on what that is,
let's
Dr. Gavin.
to try to tie this together with many things that we've talked about in some of our other webinars. Remember, there are various types of heart failure. What they all have in common is that the heart is unable to pump out enough blood with each contraction, so that you have reduced presentation of adequate blood in your system. There's heart failure with reduced ejection fraction. That's called HFrEF. Okay, that is probably the type that we have seen most commonly, where the heart is big and floppy. Okay, the heart muscle is dilated, it's weak, and it just can't pump out very much because it's a weak muscle. HFpEF, which is heart failure with preserved ejection fraction, it may be ejecting 50% or more of what blood is there, but it's so little blood there. The muscle of the heart is stiff. It's hardened, so that it is the most difficult type of heart failure to treat. Even cardiologists have had a more difficult time with preserved ejection fraction types of heart failure. And this is one of the things that we're now encountering, that we're seeing more of this HFpEF type of heart failure that we're trying to get our arms around, because it's a very bad prognosis.
Thank you, Dr. Gavin. Next, kidney disease. Again, think like the heart, the chronic inflammation that we face with the various genuine diseases damages the blood vessels, the small blood vessels. That in turn compromises the blood flow to the kidney and can lead to the chronic kidney disease. We see that African American women are 2 times at higher risk for the progression of the kidney disease than white women, because they have a higher systemic inflammation, higher rate of hypertension. This is something I found very interesting too. To compound this in African, the development of this in African American women, a lot of the chemotherapy that's involved in ovarian cancer, uterine cancer, that in turn can cause kidney damage. And if we already have compromised kidney function, we're really very vulnerable, and our mortality increases with this. The kidneys, like, think of it as a little heart that's having failure as well because it's not getting the adequate blood flow that it needs. Next. Okay. Again, Dr. Gavin, I'm going to ask you to elaborate on this. Because we've talked about the chronic inflammation, and
Yeah.
I think you could probably explain more how the chronic inflammation disease and the development of diabetes.
Yeah, I think it's important to realize that the theme that you hear over and over again is that chronic inflammation is a risk for increased insulin resistance. And whenever you have increased insulin resistance, your body does not react normally to the hormone insulin. That means your glucoses are likely to go up. But that's not the only thing that happens. With chronic inflammation, you have problems with blood pressure regulation. You have problems with your lipids, your LDL, that is the lousy cholesterol. You start getting damage to the endothelium, and what happens then? You start getting these little sticky plaques. And when those little plaques start forming, you now start to get increased atherosclerosis. Vessels start to be damaged. You start getting thrombi, little clots that go off and form cause heart attacks, it causes strokes. All of these things are part and parcel of what we call the cardiometabolic syndrome, which includes diabetes. Okay, so there's increased inflammation that leads to these imbalances of hormones. Remember that we talked about polycystic ovarian disease.
Hmm.
The imbalance
Yeah.
there is that these are women who have high levels of androgens. Androgens are male sex hormones. Okay, so there's this imbalance that all feeds into these vessel damages that we see, and African American women who have higher prevalences of some of these imbalances. We have higher prevalences of diabetes, and they all interact and they all drive the inflammation that leads to these vascular outcomes that cause cardiovascular problems, kidney disease, heart disease, strokes that we've talked about. And remember that women generally are somewhat protected from some of the common heart diseases. With diabetes, you lose all of that protection.
Hmm.
It's gone. Okay. It is the great leveler. You become now as much at risk for cardiovascular deaths and outcomes as men, and sometimes more. So this is why we work really hard to try to reduce these things early. Prevention and reduction of risk are the tools that we have to reduce these outcomes.
Thank you, Dr. Gavin. And remember, we had talked about polycystic ovarian syndrome, just to go over it again. It's not only a hormonal dysfunction, but there is a metabolic um, disorder under that. So it's if you're diagnosed with it, it's imperative that your gynecologist also looks for diabetes, because like part of my blood work is doing the hemoglobin A1C and the fasting blood sugar on all my patients that I might consider that I think may have polycystic ovarian syndrome. Okay. I think we kind of covered what's on this. Okay. So to put it all to, together and kind of see what we're talking about. Hopefully what I've done is when you think about GYN conditions such as fibroids, endometriosis, STDs, polycystic ovarian syndrome, keep in mind that there is some underlying condition. It creates that systemic inflammation that we talked about that causes the damage, the endothelial damage. That leads to conditions such as diabetes, dyslipidemia, hypertension, and that accelerates the chronic diseases that we've been talking about.
And Dr.
That
Bent,
leads,
just to highlight what we talked about earlier, where you see gynecologic disease, which is the focus of today's talk, as a trigger for all of these downstream events, remember there are other triggers that we've talked about: dental
right,
disease, obesity, and things of that nature that all feed into this triggering system for increased systemic inflammation.
inflammation. Yeah. And interestingly now, the leads to the worst, you know, increased gynecological worst outcomes. How, and also chronic diseases also put women of color and all women at high risk for certain cancers. For example, diabetes. A woman who's at risk for diabetes is an obese woman, no children, and she's and postmenopausal, and that puts her at increased risk. So it's this vicious cycle. So breaking the cycle with is what's important to hopefully get started on at least dealing with it. Next slide. Next, I'm sorry. So how can we do this? We need to talk about, and we've mentioned it, what are some of the non-medical forces shaping these health outcomes? As you can see in this pie graph, there's structural inequalities, not individual behavior. And that was so important for me to make a point of. It's not the individual behavior of the woman that's of the African American woman that's causing these worse outcomes. But there's a lot of structural inequalities. The biggest one there is access to care. There's limited preventative services for us. In the United States, we attack diseases after it's occurred. We're on the east in Eastern medicine. We tend to look at it, preventatively. So if we can at least start with that, there's delayed diagnosis because of insurance status, provider bias. A lot of providers are not listening to us. And then, of course, environmental exposures. But I do think it's the systemic inequalities that exist is one of the biggest drivers of why we see such worse outcomes in women of color. Next. And same thing with diagnostic disparities. Women of color are being diagnosed later on when they have the disease because of the access, because of the implicit bias when we go to our providers. And it's interesting, the endometrial cancer screening, for example, one of the symptoms of GYN cancer is postmenopausal bleeding, or any kind of uterine bleeding, any kind of abnormal uterine bleeding. It's important that your gynecologist talk about screening by doing biopsies, and sometimes that's not done. So you have the delayed diagnosis of those conditions that leads to the worse outcomes. Gaps in follow-up care. Women of color, we tend to not be able to follow up with when we get an abnormal pap or go back for our biopsy results because we're so busy, with life. And the implicit bias, meaning once we make the diagnosis, getting access to the appropriate doctor, the GYN oncologist, the medical oncologist, to get the appropriate therapy, that there's implicit bias with that as well. The Black women with cervical cancer were diagnosed at a later stage than white women, even after adjusting for socioeconomic status. And next. The treatment disparities, very important. I kind of mentioned this. Women of color, we don't have access, for example, to treatment of endometriosis, treatment of even any kind of GYN cancers, ovarian cancer, endometrial cancers. Robotic surgery is a great tool to treat these conditions, and a lot of women of color don't have access to that. It depends on the level of skill of the gynecologist. Black women with endometriosis and early stage cancers are less likely to be offered fertility sparing treatments. Now, one of the sad things that I see in women of color with regard to fertility, by the time the woman realizes that she's not able to get pregnant, her access to get the appropriate treatment to help with that is limited, mainly because of insurance gaps. GYN specialists, the oncologists, the medical oncologists, we're limited access to that. So you put all of that together, that's why we have worse outcomes. In the next slide. Next. Next. Okay. So how can we reduce this? And this is important. We need to be able to expand screening. That may involve community-based screening, outreach programs, mobile clinics, education, getting into the community, educating women about HPV screening, uterine cancer screening, and training providers to be aware of the cultural differences in terms of know how to talk to your patient from where they're at. Standardize care pathways. And as I mentioned earlier, I don't do research, but a lot of research, if we can get more people of color involved in our studies, I think that will help us and improve the survival. The next. To summarize, this cycle can be broken. There's a lot of work and at different levels. A lot of it is systemic in terms of the inequities by not providing us with just as equal access to treatment and prevention. GYN diseases disproportionately affect African women, earlier, harder, worse outcomes. Chronic inflammation. If you don't understand anything else, understand what chronic inflammation does to our bodies, and that's what leads to the worst outcome. So, again, it's not a medical imperative, it's moral. Thank you very much. I hope I've taught you something.
This has been really, really very comprehensive, and thank you so much. Let me ask if there are additional questions from our audience. But before we open it up for questions, remember that you will be getting the post-test surveys, and it's really important that you complete those and send those back in. That's such an important feature of this Closing the Gap initiative. So be on the alert for those and be prompt in sending those back in. Okay. Any additional questions?
Hello, can you hear me?
Yes, I
Yes,
can.
Ms. Fields.
Good afternoon. I'm gonna turn my camera on so y'all can see me. Yes, so I had asked because I had my IUD changed out. I kind of came in late on the conversation, but I was
Mhm.
asking initially how much is too much bleeding? Like when do you know it's too much? I'm not bleeding like a month like that lady, but I tampon pad, diaper, I'm all outside of everything. And it's since I have my IUD changed, so I have my iron just checked. Now they say I have low iron. And so it's just like at what point maybe do I have something more serious going on, but nobody's not tracking like
Okay. That's an interesting question because I have, when you talk about excessive bleeding, a lot of my patients, women of color, I said, well, how heavy are your periods? 7 to 10 days. Well, that's heavy. That's long. How many pads are you going through? You ask questions like that. How many pads? How many tampons? How much are you changing? Oh, I have to change it every hour. That's heavy. And then a lot of women, a lot of us think that that heavy bleeding is normal and it's not necessarily normal. So it's all relative. But if you have an IUD, because that's another one form of treatment for heavy bleeding, depending on which one you have. But if you think that you're bleeding too much, then that's you. That's your perception, and you should talk to your gynecologist, checking your hemoglobin, checking your your blood count, because that creates anemia. Anemia creates strain on the heart, and then that accelerates the development of heart disease. Does that clarify? But you should, it depends on what IUD you have. The IUD is a form of the Mirena, the Kylena, the Skyla. That's a form of treating
Yeah.
excessive bleeding. But if you're still
Yeah.
having bleeding with that, that needs to be addressed
Mm-hmm.
because there are a lot other treatment options as well.
Okay, thank you.
You're welcome.
Additional questions?
Thank you so much for the presentation. It was very helpful. I did have a question in regards to like, are there any pre-screening for ovarian cancer? Because I know with cervical cancer, like you said, we have our pap smears. But what about ovarian cancer? And are there any like abnormal gynecological symptoms we should look out for and discuss with our OBGYN?
Okay. That's a good question. Unfortunately, there isn't any standard screening test for ovarian cancer. One of the things you think I look at is the history. If there's a history of ovarian cancer, and that's another thing, that there's limited access to women of color. There is a genetic component of developing ovarian cancer. The BRCA gene for ovarian, uterine, and colon cancer. That's a question that you should talk to your gynecologist about, but it's really a good history. The symptoms that you have where you may have ovarian cancer, they're so nonspecific. It's bloating, pelvic pain, constipation, etc. But by the time you get those, you've gotten to advanced diseases. So it has a lot to do with the history and seeing if you're a candidate for the genetic screening for ovarian and breast cancer. But there is not any one standard test for screening. Some people say the CA-125, you have to be very careful of that because it's not a specific test for ovarian cancer. It can be, you can see it with endometriosis, chronic inflammation, and you just don't want to do a test. You get an abnormal result, and then you go chasing, where's this coming from? So I think it's just making sure you get your checkups, but bloating and persistent abdominal pain, it might be a good place to start with.
Thank you so much, Dr. Ben.
You're
Dr. Ben,
welcome.
we have one last question here, and it is the question is, what is your recommendation for a woman who has fibroids outside the uterus and is beginning in vitro fertilization procedures? Is it necessary to remove those fibroids via myomectomy before the embryo transfer?
Okay, good question. If the fibroid is outside of the uterus and it's nowhere impacting on the inside where the embryo is going to be implanted, not necessarily, because removing fibroids take what's called myomectomy. Surgery on a whole causes inflammation and scarring. So you don't really want to go ahead and do anything that might increase the scarring on inside. So if your womb inside, and this should be determined by your reproductive gynecologist or in vitro gynecologist. It's not necessary to remove the ones on the outside, and I wouldn't recommend it, especially if it's not interfering with the implantation.
Okay. Thank you so very much. And thank all of you for your attendance and for your questions. Remember the post-test surveys that are so important to us. Let us bow. Father God, we are thankful for what we have heard, what we have seen, and the fellowship that we have enjoyed, the knowledge that we have exchanged today. We hope that it has informed your people in a way that leads them to better health. We're thankful for such opportunities. We're thankful for those who have come. We hope that in the future, others will receive this benefit according to your will and purpose. We thank you, and we depart from this place now and ask for your blessings as we go. In the precious name of Jesus, we pray. Amen.
Amen.
Thank you all.